I've spent nearly a quarter of a century dealing with clinicians, watching and their support teams, watching surgery, um, learning and explaining about sutures. About a week ago, about a month ago, I saw a forum where a young new person to operating room or theatres, as it's called in the UK, asked the simple question: can anyone tell me where I can go to get sutures explained to me? And it made me think, well, with my experience, potentially I could do a little video to try and explain things to you. Just want to make the point, this is just an introduction to sutures. Do not make any decisions based on anything I say contained in this video. Read the information for use leaflets that come in the package inserts. Look at company websites, educational materials, and they will give you specific details on products. If you're a patient or a relative who's looking at this, then seek professional advice. Don't rely on what's on this video for any decisions. Anyway, so I realised that I've been doing these presentations for 25 years to lots of different disciplines, both inside operating rooms and other parts of hospitals, and indeed out in the community. And it didn't matter where I did it, it could come down to even to senior trainee surgeons and people who are just coming into theatres. It didn't really make a lot of difference where I was as to what I would teach. So I'll get straight into it. I would start with a basic question. When you take the suture out of a pack and have a look at it, there's one thing, if you run it through your fingers, that you'd probably be able to tell. If you run it through your fingers, how's it feel? And I'll put a little box up and I'll say a suture's either one thing or another. And this first one I'm thinking about is whether it's a single strand or multi-strands. If you cut it, would it feel spiky, or would it potentially be feather into lots of soft sort of threads? So a suture is either a monofilament or a multifilament. Okay, one or the other. You can get sutures, certain brands that are available in both, but in terms of its actual construction, it'll either be a monofilament or pretty much a multifilament. That might be called braided, it might be called twisted, but the multifilaments have more than one filament. So there's a good thing and a bad thing about most of the decisions you make with sutures. So what do you think might be good about monofilament? I'm going to do this video in such a way that when I ask a question like that, you could, if you want, pause it and discuss it with your friends and colleagues, and then come back and have a look at the answers I typically get from people. If not, just carry on. So what are the good things about a monofilament? Often you get people coming back saying things like, well, they're strong. Well, that's true, but sometimes multifilaments can be as strong, if not stronger. It varies. They're smooth. Now that is a good point, and that's probably the main reason people use monofilaments. Smooth in the sense they run through the tissue quite easily. If you think about things like textile, if you stitch, man, I must do this. If you were to stitch with just a piece of normal sewing cotton, which is a multifilament, it will hold very well. You can potentially tie knots, but if you did a sort of running stitch like you might have here and were to pull the thing through, if you grab hold of one bit of a monofilament and pull it, if it wasn't knotted, you may well be able to pull the whole lot off, and your sleeve would fall off. Whereas that wouldn't be the case with the multifilament. So monofilaments are smooth, and the passage through the tissue is very easy, very smooth, and that reduces the amount of trauma to the tissues. So that's the good side of them. The negative side of them, you might get this one quite quickly. Can you really think? Most likely people talk about, well, maybe there's more chance that bacteria, bugs can cling to the multifilament suture, and there might be some merit in that thought. And the opposite, that they're going to be a bit more drag as you push them through tissue. But the plus side of them is the fact that they're easier to knot. If you have to tie a knot in a traditional monofilament fishing line, you probably know you have to learn special knots. Whereas with silk and the like normal multifilament sewing cotton, you can pretty much do any sort of knot, a granny knot even, which is clockwise, whatever you're going to call it, or even a reef knot will hold very well with a multifilament. Blah blah blah. Okay, so often what's good about one is bad about the other. So monofilaments are very smooth, run through the passage tissue well. Multifilaments are less smooth, obviously don't run through the tissue as well. But the plus side is there's a lot of friction because it's not a smooth surface, so they're easier to tie knots. Monofilament, the negative side of it is you have to learn specialist knots, or be very careful about the knots that you are tying, especially if it's a fairly rigid monofilament. Some monofilaments are smoother than others. Okay, the next thing to think about, which you can vaguely tell when you get out of the pack, is whether or not the suture is man-made, synthetic, or natural. So we'll put synthetic and we'll put natural next. Okay, I'll just put NAT for natural. What are the advantages of a synthetic material? Okay, hopefully you've thought about that. It's probably, yes, going to be more predictable in the way you make it. So it's going to behave in the same way regularly. It's also a lot less likely, I would say, to cause the body to react to it. And I think back to when I was a kid, if I got a rose splinter, rose thorn in my hand, or maybe a bit of wood off a fence that I was climbing over, if I didn't get that out and left it, it would go kind of pussy after a few days, and you could always, as a kid, sort of squeeze on it like that and hopefully get it out, or get some sort of a sharp object and poke at it and try and get it out, typical lad type thing. But I remember when I was a bit older, I got a glass splinter in my hand, and it didn't do the same thing. It just sort of stayed there, and I knew it was under the skin, and I couldn't quite get it out, so I left it and didn't worry about it. But it started to irritate me when I could feel it, and eventually I started to get to it, and I sort of almost bit my way down to it and got it out. I was surprised. I was expecting to find a shiny piece of metal, so a shiny piece of glass, and in fact what I found was a white sort of substance. And what I understand now has happened, that the body recognised it was a foreign body, but didn't think it was dangerous. It was not biological, so the body just encapsulates things like that with tissue, connective tissue I think it is, and that's why it was white. And I'm talking for too long. It's already 8 minutes and I haven't even done synthetics. Jeez, I've forgotten a lot of this as well. The natural materials, which there's only a few still available in most of Europe, which is probably silk really, but silk, linen, catgut have all been available in the UK in the past, and are available in many countries still, I believe. The stories I remember there is, again, having a piece of silk in this particular wound. The stitches were removed, and then several weeks later I felt an itch sort of thing, and I scratched at it, and just a little bit of black silk that had sloughed off came out. And my mother, who was a nurse during the Second World War, told me that she went to a reunion once and met one of the guys that had been what are called guinea pigs, people who'd had plastic surgery after they had bad burns during the Second World War. And this gentleman found out that her son worked for a suture company, and he told her the story of a little piece of silk that had come out of his neck something like 30 years after it had been put in. So the body can, in certain circumstances, not routinely, just try and reject a natural material, and it's not always going to be a problem, but it's something to think about. Okay, so the third thing to think either or is, you can't really tell this from the suture as you feel it, but you can by reading the package, is whether or not the stitch absorbs or is non-absorbable. Okay. Sometimes you see people talk about dissolving sutures, and that's not a really good term to use, I'd suggest. It implies something like putting something into water and it'll just sort of dissolve and you won't be able to see it. It doesn't work like that. Absorbable sutures are either absorbed by hydrolysis, which is the common one for the synthetic materials, or something that I'm beginning to forget about, but enzymes for catgut. The body recognises catgut as a foreign protein and eats it up using enzymes. The synthetic materials, basically water gets into the suture, breaks up the bonds between the individual stitches and between the individual molecules, and that's how it breaks down and eventually goes out of the body through breathing and through your urinary system, going to the toilet. Okay, so non-absorbables, mostly we'll talk about stitches that last for a long time. Some of you who've worked in operating theatres for a while will notice that you don't see double-ended needles, which are commonly used, two needles on the end of both ends of a piece of thread. They're commonly used in vascular surgery, and you'll notice in that range that there are monofilament synthetic non-absorbable sutures that aren't in that range. There's polypropylenes and the like that do not biodegrade, in my understanding, so they're non-absorbable forever. People may dig up people who've had coronary artery bypass grafts in the 20th century, find a bunch of bones and I think little bits of polypropylene. But there are other ones, the nylon type products, that do, I believe, biodegrade. So they break down, they don't hydrolysize. In other words, they take a lot longer to break down. I'm no plastics expert, but that's worth bearing in mind. But in the main, what we're talking about with absorbables is how long they support a wound for as they gradually lose strength. And I'll come back to that in a lot more detail in a sec. Okay. Good. So if you look at the range of sutures you have in your place of work, you'll find you could pretty much look at them and say, okay, that's a monofilament, it's a synthetic, and it's absorbable. Or that's a multifilament, that's natural, and that's non-absorbable. So for example, silk is a multifilament, natural, non-absorbable. I don't want to go through the trade names, but some of the most commonly used absorbable synthetic sutures in theatres that are usually coloured violet are multifilament synthetic absorbables. But you also have versions of sutures that are monofilament synthetic and absorbable. And not all of those are the same as not all multifilament synthetic absorbables are the same. You need to look at how long they take to absorb and what absorption actually means, which we'll soon come on to. The synthetic materials, by the way, often have coatings added to them, which makes a change. The synthetic multifilaments will often have a coating that allows the passage through the tissue a bit more smoothly. It also, in some cases, allows you to do a square knot, a left over right, right over left, reef knot, square knot, or clockwise once, anti-clockwise once. That gives you a square knot, the way you should tie your shoes, by the way. The loops will sit like that if you tie them right. If you've done left over right, you'll end up with your loops going like that, which is a problem if you ever tie a bow on the back of someone's dress. But the point is, the coatings can help with that, and some of the coatings have more affinity for the sutures than others and can come off, or certainly if they get wet they'll tend to come off, and some sutures obviously do get wet. In fact, most of them will get wet. So before you get too excited about trying a suture, try it while it's wet, because you might be able to tie a certain knot. For instance, there used to be one suture that people got used to doing a double throw, clockwise, and sliding that down, and that would then hold, and then put another throw on top of it, and obviously that would tend to lock. With one of the newer synthetic absorbable multifilaments with good coating on it, you're able to tie a clockwise, anti-clockwise, reef knot, square knot, and then slide that down into place, and then put a locking throw on top of it. And that isn't always the case with some materials on the market, and something that kept me quite busy for several years, just showing that you could do that with a coated material if it got a good coating on it. Okay, now for the sake of completeness, I will add one more thing. I think the box of 6 idea, which is what I was taught and what I used to show to everybody else, is probably now fairer to call it a box of 8, because the other aspect of sutures that is available in some countries throughout the world is whether or not the suture has any antibacterial properties or not. So let's call those standard sutures. It's an area that isn't simple to come to conclusions about, I don't think. I've talked about this with a number of people, including some people I trained out in Africa. One of the guys in Africa just said this, which I thought was interesting. He was talking to a surgeon. He said, if you're doing a wound and you know you've got an infection near the surface, what's one of the first things you do? And the surgeon said, well, remove the suture. And that, to me, was a good point. It indicates that an infected suture is potentially a problem. It's a bit like if you look at a rope next to a boat in a harbour. If you pull that rope out of the water, you often find it's got a sort of a slime layer on it, and that's called a biofilm. And biofilms are very hard to get off. My understanding from the lecture we had from a guy from Manchester University, I think it was that the outer layer of a biofilm, the very inner layer that's touching the suture, is effectively dead. So there's not many things that can get to it and remove it. So you end up with this sort of slimy layer on sutures if they get infected. And removing that is very, very difficult. And I think often, people know that you have to scrub things off when you've got a slimy layer on. Probably the same as cleaning out your sink. If you've got that slimy layer, you really have to scrub it sometimes to get rid of it. If you can prevent it in the first place, maybe that's a good thing. And the antibacterial sutures that are available at the moment have an antiseptic in them, not an antibiotic. So there's no issue with antibiotic resistance, I don't think. But antiseptics, obviously that's something where there isn't, to my knowledge, much examples of resistance to antiseptics, but it's a new factor and it's something that there needs to be lots of clinical papers looking at to understand it fully. And those papers are starting to be out there. And then there's a health economics element of it. I've said to some surgeons, if you have a choice of using suture you can grow bugs on or one you can't, which would you prefer? And most of the time, not always, if it's proven, they'd say, well, the one you can't, obviously. But these sutures cost more money, so you have to look at whether or not the extra cost pays for itself. And the other problem in so many countries is whether the savings actually come from the person to the person that's having to pay for the extra cost of the sutures. And of course, that's very rarely the case. So moving money from one place to another within most health organisations is an extremely difficult thing to sort out. Probably an area I shouldn't get too heavily into. It's not something I'm now involved in directly, so I'll leave that for you to do the research and talk about with your friends and colleagues. So you could add, certain sutures, and they are available in both monofilament and multifilament. Multifilament, say, synthetic absorbable antibacterials, or silk, going back to that, would be a multifilament, natural, non-absorbable, standard, non-antibacterial suture. Not something I would regularly worry about, but if you're in a hospital that is using both the antibacterial and non-antibacterial sutures, you can see it's something you should be able to understand, at least have a basic idea of, and it could be helpful to you in the future. Okay, so that's the materials in the main. If you look at a length of material without a needle on it, then often that's called a tie or a length, and they're mostly used for either ligating, just tying off a blood vessel or a vein to stop it leaking, or anything else that's a tube that contains a fluid. You're tying it around it to stop it from leaking. Most tubes that leak in the body cause problems, some of them quite serious if you let them go on for too long. So you want something that ties well, it's a nice firm knot. So it's still relatively common to find that you might use silk even in those situations because it ties very well. Most commonly it's going to be a multifilament material, sometimes absorbable, sometimes not. It'll depend on the pressures involved and how well the tissue could heal and things like that. And another thing that occasionally people do is transfix these ligaments and things like that, which have veins and arteries. But for that, you probably would most commonly have, for that you'd need a needle. You might use a pop-off needle, as they call it, control release needle. That's a trade name, can't use that. But pop it through and then you tie it off, and the idea there is the stitch in it. I think I probably should cover that later, actually, not now. Okay, so let's stop at that point. That's the materials. At the bottom of this video you should see there's a little thing that says, you know, materials, and then we move on to the next section and it will say absorbables. If you want to stop the video at that point, you can come back to it and watch the next segment. I think it stops the video from getting too hard to absorb. You can do it bit by bit, and if you're doing a lecture or a few classes, you could maybe use this video, stop it, have a debate with your students, get it a bit further, and then move on if you choose to. Okay. So the next thing is absorbable sutures. It's not as simple as a lot of people think, and I've dealt with some relatively senior surgeons who, when I've talked to them, I realise haven't really thought too carefully about the three factors that I would say you need to think about with absorbables. Of course, some surgeons know it in great detail, and I've talked to people, one who visited the factory for the company I used to work for, who'd just remembered everything he'd ever learned, and he was quoting all sorts of interesting things to do with physics, more or less, but still. Without getting too technical, I think there's three things you want to think about. First one is tensile strength retention. The second one is total mass absorption. And the third one, I haven't come up with a decent technical term for this, is how long does it take for the knot to drop off if you're using a suture externally. Now, what I do with the tensile strength is just draw a graph. Okay, if you start off with a suture at 100% strength, and then you've got the number of days, and I'm not going to put any dates on this because that would mean you might be getting decisions about how long a suture lasts in terms of tensile strength. But if we say roughly, you know, about a month, if you went like that, okay, that might be a fairly typical loss of strength graph. Not necessarily a straight line, but it's usually something close to that in a lot of the synthetic materials. Anyway, so it's going from 100% strength to very little strength after what, you know, might be a few weeks, a few days, a few months, depends on the suture. But what you need to think about is how long do you need the suture to be there for? I didn't do the plus and minuses of sutures of absorbables, did I? Okay, so 50%, you can see that many days, 25%, that many days, okay? And what you need to do is compare that with a graph of how long does it take the tissue to heal. Does it heal in a line like that, or does it heal in a line like that? Okay, and work out whether or not you have the optimum tensile strength retention to give the wound the support it needs until it regains its own strength, or are you dealing with a tissue that never heals? You know, it might be if you put stitching in a prosthetic graft that it never heals to the tissue, in which case you don't need an absorbable suture, you need a non-absorbable suture. In fact, you probably need a non-absorbable suture that doesn't biodegrade, hence polypropylene, commonly used in vascular surgery, where prosthetic grafts can sometimes, quite regularly, be used. Okay, so that's the first thing, that's total tensile strength retention. Okay, but you can go back into a wound potentially after a few weeks or months even, and the suture will still be there. It'll look like it's there, but if you were to get a pair of forceps and grab it and pick on it and just pull it, you'd discover that there's no useful strength left there. And I remember my original boss in the suture company reminded me of something like what he called blotting paper, but most of you probably don't know what blotting paper is, but kitchen rolls. Some kitchen rolls, not all, when they're dry, they've got some strength. When they're wet, they sort of fall apart. Now, it's not the same thing, but it's similar in the sense that if you see a suture after it's absorbed, lost virtually all of its tensile strength, there may still be something there. But if you were to just get the forceps, you could pull it apart easily, just fall apart. There'd be nothing there really. So just because something looks like it's there, it doesn't mean it's got any strength left in it. So, you know, dry paper, dry blotting paper, wet blotting paper look very similar, but one was no strength at all, and one's got a little bit of strength. And that's got to be a very, very dangerous thing if you don't understand that, because if you see that the sutures take 6 months for the total mass absorption, you might think it will support the wound for 6 months, and that is not the case. And that could be very dangerous if you used a suture in a place where it needs, you know, several months of support, and in fact you hadn't got that because you'd misunderstood the data in the package for use. So look very carefully at tensile strength retention or similar terms to that, and look at that for what's important for the choice of suture. And occasionally you may need to think whether the total mass absorption is going to be a factor. Now, a good case of that is there are monofilament synthetic absorbable sutures that last a long time and ones that don't last a long time in terms of tensile strength. When there was only a long-lasting suture available, a lot of people used it for subcuticular closing. But what they'd find was, although the wounds healed okay, the stitch being around for a long time became irritating to patients and sometimes caused a problem. So when a synthetic monofilament absorbable suture came which had less length of tensile strength, but therefore as a result, and this is usually the case, less time for total mass absorption, that became much more popular for skin closure, because people don't really want to be able to feel a stitch hanging around for 6, 7, 8 months, something like that. They'd rather have one that only hung around for, I don't know, 3, 4 months, even though the actual wound support it gave, the tensile strength retention it gave, was only, you know, a month or so. So you get the idea, it might support for a month, but it might take 3 months to disappear, or it might support for 2 months, but it takes, you know, 6 months to disappear. And of course, when I say supports, that's arguable because the grafts are always going like that. You're losing strength. So you've got to think, is the wound healing to the point that loss of strength is okay? So the third thing, which is a bit bizarre, but is just not drop off. If you use a suture externally, or where it can be felt or got to, so, you know, if you're using a stitch in the mouth for, say, after you fixed got it taken a wisdom tooth out and there's some bleeding, you really don't, going back to the monofilaments, they're quite spiky. You don't want a monofilament most of the time in your mouth. Similarly, if you're a lady having a episiotomy repair, you probably don't want to sit on something too spiky that feels a bit like barbed wire. So multifilaments can be good in that situation. But in the mouth, if you put a stitch in your mouth and the stitch hung around for weeks, that would be terribly irritating. So having a stitch removed from your mouth might be the answer. That's what I had originally with silk, you know, but it caused a bit of reaction. It was rather irritating, and getting it out was a bit annoying. In fact, my dentist once forgot to take one out, and he swore that he couldn't have done, but when I went back he went, oops, sorry, and took it out. But a multifilament material probably less irritating to the tongue, but some of them will hang around too long, and there are some fast absorbing multifilament synthetic absorbable sutures that are now commonly used in things like oral surgery. They might be used for the skin in a episiotomy repair, potentially. If you do a subcuticular stitch, it's not so much an issue, but if you're doing a stitch where it's external, similarly you might have it, not much use for me, but if you've got a hairline and you had a cut here, you might use them in the scalp. In general, they're also used sometimes for paediatrics where you don't want to have to take a stitch out because the kid has to maybe be sedated or anaesthetised. The point of a stitch that just falls out is it could be good, but you can't guarantee, if you just wait for it to fall out, you can't guarantee that there won't be little bits sticking up, okay? And those little bits gather a bit of muck, okay? And that can cause a localised sort of infection reaction, and you don't get a great scar result. You might get a little bit of reaction which causes a scar. So in the main, it's quite rare that are fast absorbing. By that I mean one that probably only gives wound support for a week or so will be used on the face, and I think mostly they're contraindicated because they can give some poor cosmetic results. Okay, but again, like I say, I'm not an expert. Check the information for use before you quote anything to anybody or making research, and don't, for whatever you say, oh, this guy said blah blah blah. Okay, you've got the information out there, you just need to read it to make those decisions. Okay, so that's the end of the basic overview of the three things involved with absorbable sutures: the tensile strength retention, how long the total mass absorption is before there's nothing left, and how long would it take if you had an external knot for that knot to drop off. Okay, there's certain sutures that if used as an external knot, despite the fact they said absorbable, they would be there for absolutely ages. There were stories in the early days of some of the monofilament synthetic absorbables that lasted a long time, of drunks having stitches done in their heads and turning up months later, and they would still be there, of course, because they won't have broken down in that time. Okay, so relevant stuff. Okay, so that's the end of the absorbable bit. The next bit is just to go back to some extra things about the materials. Yeah, material colours. Mostly the colours are there to help you be able to see the sutures. In the case of a stitch that's going to be under the skin, the colours might be to help you not be able to see the sutures, because a clear suture or a pale suture, usually a white suture, won't show up through somebody's relatively thin skin, maybe if they're elderly, if they've had a subcuticular stitch, which is a stitch that goes just underneath the skin, subcuticular. But we'll come later to the colours of the packs. That isn't necessarily the same as the colour of the suture inside it. And some sutures are available both in coloured versions and uncoloured versions. And one thing I'll say this again later, but just because a suture's one colour doesn't mean it's the same suture. Violet's a very commonly used colour. There's only a certain number of colours that are considered normal or safe, or whatever you want to call it, for use in sutures. So most of the manufacturers use those colours and variations on them, but you could colour a suture that's actually quite different to another in the same colour. It doesn't mean it's got the same tensile strength profile, the same mass absorption, or the same knot drop-off time. So watch out for that, and that's obviously much more relevant if you're switching from one manufacturer to another. You may find there's some changes which could be an issue. You might think, well, it doesn't really matter, but in some cases, say if you're tying off a vessel and you find that you can't slide the knot down, and that's the technique you're used to, there's a slight chance that the knot will lock prematurely, and you maybe haven't tied off I forgot what they're called. In gynae, what are those things called? Can't remember. Blah 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 blah. Okay. Anyway, so colours of the materials vary. Yeah, silk's available in black. I think you can get a white version of it. Polypropylene often is blue, but again you can get clear versions of that. One of the most common subcuticular stitches is sort of a straw colour. Just trying to think of anything else. Nylon, often either black or occasionally a lighter sort of green colour, I think. I'm beginning to forget. Anyway, you get the idea. So the next thing is something we inherited certainly in the UK from the textile industry, and it's used quite a lot throughout the world, not exclusively. The actual metric system, which you'll see in some of the packs in more detail, and sometimes it's in brackets, is more logical. You can work out the actual genuine diameter of a suture from that if you understand it well, but it's not used in many countries, or certainly not the countries I've had contact with. The more common old system comes from, I believe, the textile industry, because if you look at old sewing cotton that your granny might have hidden away somewhere, you sometimes will see this on it. And it goes from a rather bizarre system of what's called 11-0. Okay, you might say 11 noughts, but I think 11/0 is the normal way, or 11-0. Okay, and that's very fine. That's the sort of stuff that's used on corneal grafts, and if you look at someone who's had a corneal graft, you probably won't be able to see it unless you look really, really carefully in the eye, and you'll see this sort of little, almost like crisscross sort of thing going all the way around their eye. Okay, and that's quite impressive, and that's way thinner than the human hair. Okay, and 11-0, the next thickest, which is still very thin, is 10-0, then 9-0, then 8-0. Now the 11-0, 10-0, 9-0 is the sort of thing that are used in ophthalmics and neuro, nerve repair, that sort of thing. Okay, the next thicker, 8/0, 6/0, 5/0, that sort of range, maybe 9/0s occasionally, are used in vascular and cardiac surgery. The next, so 11/0, 10/0, 9/0, 8/0, 6/0, 5/0. When you get into the sort of 5/0s, 4/0s, 3/0s, 2/0s, they tend to be used in skin sutures and bowel surgery and stuff like that. That's sort of gauge urology internally. The finer they are, the more likely they're used on a smaller wound. The younger the patient, the more likely it is they'll be used a slightly finer gauge. So what you might use at 4/0 on an adult, you might use at 5/0 on a kid. That sort of thinking. And then when you get to 2/0, that's when there's a strange change where it goes to O, okay, which you can almost think of as if it was like those are the negative below O, thinner than O, and these are the positives, thicker than O's. You go to the 1s, 2s, 3, 4s, and I think the thickest that's commonly available is a 5, okay? And that's the sort of thing that's used for closing fascial layers. You might think you actually close muscles, but often you might put a stitch through a muscle, but the really strong area is the fascia. And I asked a surgeon once, and he said, yeah, that's about right, James. I remember when I was a first student, did my own first bit of cooking. I got a piece of chicken, and there was a sort of a very thin, very tough layer, shiny layer that I could almost see through on the chicken, and I couldn't get it off, and I couldn't figure out what it was. And that was very, very strong, even though it was incredibly thin. And you couldn't bite through it if it wasn't cooked. You know, it'd be really hard. Even if it is cooked, it's probably hard. And that layer, that fascial layer, is often what needs to be stitched together, because that's what gives the real strength. You've got to be very careful actually putting tight stitches through muscle, because that could cut off the blood supply. So although the stitch might go through the muscle, they don't put it on too tight. But that's another aside maybe. But the point is, the thicker gauges you might most commonly see being used in orthopedics, gynae, midline closure. So midline, that's down here. There's called a linear alba, which means literally white line, and that's the way some surgeons will cut you if they're going into the abdomen. Not always. Okay, and that's a good example where that wound takes a little bit more time to heal. We'll come back to that maybe. Linear alba basically means white line. Anything that's white's probably got less blood supply, so it might take longer to heal. Good. You know, notice this is good talking this close, but it's not good because you can't see what I'm drawing. If I'm on the board, will that work? Anyway, okay. So that's the rough idea on that. Now, let's just talk a little bit more about surgery, because then you might understand more why there's such a big combination of materials and needles, which is the next thing I'm going to say. So that's the end of the materials sort of second section, and now I'm going to head towards talking about needles. But if you think about, say, a house, if you were working on a house and you wanted to get to the plumbing, sometimes you're going to have to take down the plasterboard. I think it's got another name in America, hasn't it? But the stuff that's covering the walls, you might have to take a bit of that away to get to the pipes. Similarly, if you work on the electrics, you might have to do that. Okay, once you've got to that, you may close that wound. So put back the plasterboard, and then once that's okay, you skim that and let that dry, and then maybe put some wallpaper or paint on top of that. And you know, it's not a great analogy, but sometimes that's what surgery is. You're getting access to the bits you've got to work on, and then you have to close on top of that. And usually, not always, but you know, you go through the skin, then you go through a layer of fat, which doesn't usually need many stitches in it, or any stitches in it. Then you go through fascia and muscle layers, and that needs to be repaired. And then through another layer called the peritoneum or the pleura, if you're in the abdomen or in the chest, that layer is sometimes repaired, but usually it's taken with a stitch that closes the fascial layers, the muscle layers together as well. But usually the surgeons are getting through the skin, the fat, the fascia to get to something that they're working on. So the orthopods will be working on the bricks, the skeleton of the body, and some of the neuro people will be doing the same, back surgeons and the like, that might be working on the bones. Or they're going to try and get to the nerves, if they're not doing repairs on the actual skeletal system. But an awful lot of surgeons are actually trying to get to a pipe system, which is crude and not surgical speak, but I think will help you understand it, where fundamentally they've got a problem with either they have to fix something, take something out that shouldn't be there, I wish it wasn't there, but it is there. They're removing that, and then they're trying to redo the plumbing, so to speak. And or they may have pipes that are full of rubbish, and they've got to open up those pipes, either remove the rubbish or replace that bit of piping, or try and join the good bit of pipe to the good bit of pipe, having removed the pipe that's blocked in some way. But if you think about pipes in the body, you've got, for instance, put food in here and it comes out the bottom end. That's called the GI tract, the alimentary canal. You're going down the esophagus into the stomach, out through the duodenum, jejunum, into what's called the small bowel, which is the thinner stuff. It looks about like that, and that's a great joy of my job. I watched surgery for 25 years, so I've seen this. Your large bowel, which is kind of that sort of diameter. I've usually seen it when it's empty, because people are prepped for operations, but obviously that's where things build up before you go to the loo. What's my point? That's big pipes, whatever. But those vessels, so bowel, okay. Think about another one. If you think about the heart, from the heart, generally speaking, you refer to things going away from the heart as arteries. That taking oxygenated blood out to the extremes of your body, up into your brain, down to your feet, to back of your arms, and then the blood's returned back to your heart through veins. Okay, most of the time. It gets slightly more interesting when you think about things go from your heart to your lungs to get reoxygenated and come back. So in that case, you do actually have, let's get this right, you have an artery, something that's going away from the heart, that actually is deoxygenated, and the vein coming back has got the oxygen in it, I think. Okay, but generally speaking, arteries carry oxygenated blood to the extremes of the body, and veins bring it back. But if there are blockages in those or something getting in the way of those, you have to get round it, fix it. Okay. Similarly, if you drink something, eventually that ends up going through your kidneys, liver, and stuff like that, and goes out through your urinary system from your bladder down through pipes and out through your ureter or your penis. Ooh, I can't say that really, can I? I don't know. But okay, so tubes basically. And even if you think about breathing, it's a tube, okay, it's air, that's the fluid in that. But in general, it's not a good thing if those things leak. If they leak, they stop, the actual system doesn't work properly, so you need to fix it. Same as you get a leak in your pipes, it can be an absolute nightmare, can't it? You need to get that hole fixed. So you don't want to make bigger holes than you need to. So you treat all of these vessels with a great deal of respect. And one of the principles I learned early on was a surgeon taught me the principles of a good anastomosis, and that was, first of all, make sure that you've got a good blood supply. 2, make sure that it's leak proof. 3, make sure it's tension free. 4, make sure there's a good lumen size, so the actual size of the hole. If you've got a choice of fixing a pipe when the hole's that big, that's better than fixing it if it's going to be that size. If it was originally that size, you want to try and get back to sort of that size. But if you end up with a smaller hole, then you're getting less fluid going through that tissue, which is not a great thing. Okay, I wonder if I can show pictures. If I'm using a proper camera that doesn't reverse it, I can probably show things, can't I? And then I can do it with this intimate thing rather than whiteboard. Okay, so that's just a preparation for the thought of what sort of needles you're going to use for fixing these pipes in particular, and then maybe for closing the tissues as you go back out, having opened up the abdomen or the tissue to get to where you're working. Okay, if you look at a pencil tip, okay, no, okay, not a great example. That's the problem. Where's the camera's there? The camera's there. There you go. Okay. It's conical, so it's just been put in a pencil sharpener, and it's got that sort of round. And as you cut through it, you could see it would be circle, circle, circle. Draw that on the diagram. You get some slight variations in the very tip of that. I know one of the best manufacturers has a suture that, if you look very carefully at the very tip of it, it's actually just very slightly flattened, only slightly, and sort of rounded off at the end. And that's designed to help take the individual layers, for instance, when you're going through the bowel. Okay, but these types of tips are usually called something like round-bodied needles, or possibly you occasionally hear the term tapered point type needles. That can be slightly awkward because there's another suture that's commonly used that's got a name similar to that, especially in the UK. But round-bodied is what I learned as a kid. In America, I think taper point is the more commonly used name. But they're all conical, and a bit like a tip of a pencil. Okay. Now at the other extreme, there are the needles that have triangular tips. Okay. Most commonly that shape, but sometimes that shape doesn't really matter too much. And I'll draw what's called a reverse cutting needle. So if that was the curve of the needle, then that's the shape of the suture. Okay, the tip of the suture, that is. Now that's obviously got 1, 2, 3 sharp edges. So it's more like a knife or a chisel in the sense it will cut through the tissue. Okay, but if you have a round suture coming through a triangle, okay, I don't need to draw that on the whiteboard. Obviously there's a chance that you make a triangular hole with a round suture, that things leak out through the little gaps. Okay, so triangular tip needle, sometimes called a cutting or reverse cutting needle, wouldn't be used routinely on anything, a pipe, because of the risk of leaking. Also, there's a slight, at least theoretical risk, that the stitch might rip through where the triangle's been made and tear it and make it even worse. Okay, but if you're going through something as tough as skin, would you do it with a pencil? Well, you know, I've made this joke. If you're extremely angry with a partner or something, I suppose you go like that, and you could just about get a pencil through someone's skin. If you're a trained assassin, you know, like been in the Marines or something, you probably would. If you've watched Born Identity, you know, you probably could do quite a lot of damage with a pencil. But given the choice of what in the UK is called a Stanley knife, parcel knives, I think they might be called in the States, you could do a lot more damage with something with a sharp edge or a chisel, something like that, if you think about the toolbox you've got at home maybe. Okay, so that's one extreme, cutting needles, and the other extreme, less trauma, are the round body needles. So a round body needle causes less trauma, but it's difficult to get through tough tissue. A cutting needle goes through tough tissue, but it's liable to cause trauma. So those are the two rough extremes. Okay. Now, if you look at the thought of what's in between, there are effectively what I think I'll start calling hybrids, which are needles that have a basic round shape to the needle, but the very tip may have extra bits into it. So if you had a round bit and you kind of filed it that way, and that way, you could end up with a sort of something that looks like a bit like a trocar tip. Okay, and that gives you some of the benefits of a round body needle without actually being a round body needle, and the cutting sort of tip, the edges on the tip, give it some penetrating possibilities or benefits without giving quite as much trauma as a triangular tip could. Okay, and the risk of leaking. Now, those type tips are usually used for fascial closure, but not exclusively. So it doesn't mean if you're doing fascial closure you must use one of these hybrid tips, sometimes called a taper cut needle, in one of the major manufacturers' ranges. But it doesn't mean that you always have to use that. Okay, sometimes a very thick, strong needle. Oh, I didn't mention, I mentioned the diameters of the needles actually. Wire size, yeah, I do come on to that. Okay, I think that's more or less. There are other variations on needles. There's a triangular one that's had the bottom bit taken off, called a spatulated needle. That's often, for instance, used to just pick up one layer of sclera in the ophthalmic surgery. It's probably the most common place you'll see spatulated needles. There's a liver suture that's more or less just a round end, a blunt. It's got a blunt end, livers and kidneys are very friable, so stitches through those, in fact they're not that common, but if you do put a stitch through that, you want something that's not going to cause much trauma. They're very vascular, so you don't want to cause much trauma either, but they're so easy to get through that you can use effectively a blunt end. And then there are a few companies that make needles that have an end of the needle. It looks almost like a dolphin's nose. Those needles became sort of more popular when the risk of needle stick injury and the possibility of picking up blood infections from patients became an issue, and surgeons started using these sutures occasionally. Sometimes they use them routinely, sometimes they use them on high-risk patients, but I think more commonly they use them routinely if they get used to them. They tend to sort of pop through the tissue, so the good news is if they do go through the tissue and hit your finger, as long as they're not going too fast, they won't cut through your glove and into your finger, so it reduces the risk of you getting an infection. The downside of them is they take a bit more effort, and you've got to have a good technique of following the curve of the needle, and you will feel often a little bit of a pop sort of feel, and you can even sometimes hear a pop as they go through. Okay, so that brings me on to the second thing I want to say about needles. I talked about the tips, now we want to talk about handling needles. If you look at the shape of a needle, okay, and it's got the suture attachment area here, okay, the tip we've talked about, but don't grab the tip if you can help it. If you put a stitch through, say, skin, one bit of skin and then another bit of the skin, and just the tip sticking out, don't grab the tip with the needle holes and pull it out, because you'll twist the end of the needle and you'll have a little barb on it, which will spoil the suture for going through the next time. It'll cause more trauma, or you might even break off a sharp bit of metal that could drop anywhere. You don't want that. So at that point, it's probably no harm to hold it by the butt end of the needle and follow the curve to get it out. But if that's routinely happening, that probably just means you're not using a big enough needle for what you're trying to do. And big enough, I mean like long enough. Okay, most needles have a flattened section from about 1/3 of the way around to 2/3 of the way around. If you hold on to that, they also have usually a flattened top and a flattened bottom to stop the risk of a needle rotating, which can be irritating. The needle doesn't have to be square on, it might often be held at a slight angle so that you can get a better position for your needle holders to get to the tissues that you want to. And then the other end is where the sutures are attached. Now that can be done by popping a little hole in the end of the usually stainless steel with a laser, and that is probably only more common in some of the companies that have invested a lot of money, because obviously that's a relatively new technology. But that allows them to use slightly stronger metals or not keep this part of the metal soft, so that they can then crimp it, and you'll actually see a little line around the top of the suture on some manufacturers where the suture's been squashed. The needle's been squashed around the suture to sort of hold it in place. In the old days there was like a channel, the stitch was put into it, and then there was a machine that went kajunk and then kajunk, and there were people, usually ladies in the factory, I used to watch, who were going kajunk, kajunk, kajunk all day, kajunk, 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 you know, suture, needle, kajunk, kajunk, kajunk. But, you know, with the lasers it goes in and crunk. I think it's just cramped a lot easier. I'm not sure if they do it by hand now or not. But there are also people that literally sit with a very fine suture and a tiny little bit of a very specialist glue that's hardened by heat, and they dip a resin, I think they call it, dip it in, and then under a microscope put this tiny little suture into this tiny little needle. And when I say tiny little suture, this is stuff considerably thinner than human hairs that you'll see, say, stuff like corneal graft. And those ladies just and some guys just deserve greatest respect. If you thought how much effort went into making those teeny little needles and the sutures that are attached to them, you wouldn't think, wow, this is a lot of money. If you tried to make one from scratch, you wouldn't have a chance of making it for less than thousands of pounds. Okay, you know, just trying to make it down. Through mass production, those sort of things are maybe in the UK £10 a suture, something like that. And some of the most expensive sutures, but when you see what goes into it, the engineering at such a small level, they usually deserve that sort of price range. And when you think about what they do, I remember once talking to a paediatric cardiac surgeon who, after the operation, I was talking about, you know, do you think selling sutures is a worthwhile thing to do? And he put it in another way, which I thought was nice. He said, James, without that suture, I couldn't do that operation. So, you know, it's something worthwhile. Sutures aren't totally boring. They are actually quite interesting when you think. If you've ever seen a kid's heart, baby's heart, they're about the size of a walnut, which is just quite something to see. Cool, okay. So if you grip the needles at the wrong place, you'll end up with a needle that looks like that, or worse still, like that with a bit dropped off. If you look at the pictures under a microscope and see that under an electron microscope, you can actually see little bite marks, which are almost like crocodiles gone bit it. That shows that you've been holding it probably where it's softest, most likely to bend because of leverage or whatever country you come from, the way you say it. And there's a danger of it breaking off. So try not to hold it by the attachment area unless you've got the stitch all the way, nearly all the way through, and you just want to push it that last little bit further, following the curve of the needle, and then you can get it out. And you might want to think about this, generally choosing the size of the needle. If you have a wound there, and that's where you put it in, and that's where you want it to come out, then that's about the length of the suture you want, and just follow the curve of the needle and it will come out where you want. So I did this a lot when I was talking to midwives about the size of the needles. In, out. Okay, now if you watch people doing very, very fine surgery, like vascular surgery, they'll have a needle holder that's kind of that size, and they'll have the needle in the end, and to actually rotate the needle, this is what they do, they just rotate their fingers like that. Okay. A more common would be if you're watching a plastic surgeon, obviously a huge amount of suturing, skin suturing mostly, they have this I think it's called pronation, where they have the needle holders and they just rotate with their wrist, okay, bit of the fingers, but most of the wrist, and that is for the bigger needles. And then if you're watching, say, someone doing a hip surgery or a bit of general closure, they might be grabbing the tissue and actually kind of using a bit of their elbow as well as their wrist to get a bigger bite. And those are stitches that might be that sort of size. The plastic surgeons might be using ones that are that kind of length. And the ophthalmic, vascular and cardiac guys are using needles that are literally, 3, 4, 5, 6, 7 millimeters long. Tiny little things. Amazing bit of engineering when you look at it, but we take it for granted. Okay, the gauges of needles also, there's a thing called wire size. The smaller the suture, the length, generally the thinner the wire size is. So you might see a stitch used for abdominal closure that's, maybe that thick, 1 to 2 millimeters. But when it comes to skin sutures, they're going to be a bit less, 1, 2 millimeters maybe. And for the ophthalmic, vascular, cardiac stuff, less than half a millimeter, tiny little thin wire. And obviously the thinner you get, the more delicate these sutures are, and the more respect you have to treat them, both in the way that they're packaged, the way they're removed from the packaging, the way they're used with the stitches and stuff like that. Okay, next thing, curvatures of needles. Can't believe that's nearly an hour. I'm just going to sit through an hour. Okay, need a circle. I think it's irritating. Oh, I suppose I could come near the camera. I can't see what I'm doing in the camera. Need a monitor. This is more intimate, isn't it? But I'm not looking at the camera, which I would be on that. I can find things if I've got them ready. Okay, in terms of the curvatures, if you draw a circle and do a cross like that, that takes it into quarters. And if you go again, that takes it into eighths. Yeah, okay. So if I draw a line here from here to here, I'm going 2/8, which is 2 divided by 8. A quarter, 1 divided by 4. Okay, so that's a quarter circle needle, and you will see those occasionally, not too commonly in, say, ophthalmics. More common though might be a half circle needle, sorry, a 3/8 needle. So if I draw that, 1, 2, 3/8, okay, often called a curved needle, which is a bit strange really, because half a circle would be a curved needle too, but 3/8 or a curved needle, they're very commonly used for skin closure subcuticular sutures where there's easy access, easy to get to. Okay, if I draw this, okay, that's half a circle, 4/8, okay, and half a circle. If you think about, there's a famous hotel in London called the Savoy, and when I walked past it one time, it's actually the entrance to the Savoy is at the end of a very narrow street, and I suspect that only a London taxi can easily go down to the Savoy entrance and turn round and come back. So they go down and turn round, because London taxis have extremely good turning circles because they have wheels that you can turn way further round than you normally can on a car, so they can turn round kind of like that. If you're down in the pelvis, in the abdomen, you're trying to get down there, you want a needle you can get down and out, okay? If you're deep in the leg doing a vascular suture, not superficial, then you might want a needle that can go down and round. Whereas if you're near the surface, you might use a 3/8, which is why you'll see both half circle and 3/8 needles for vascular surgery. The aorta is not easy to get to, that's going to be a half circle, okay? But if you're going to maybe the carotid artery in your neck, you might use a half circle, you might use a 3/8, okay, because it's easy to get to. You get the idea. And then 5/8, so beyond half, and if you look at it on its side, it looks like that, okay, a bit like a sort of an earring, not quite that's for areas of very difficult access and not commonly used, but I've seen them in maxillofacial surgery when it's difficult places to get to, but most commonly in urology, okay. Probably less commonly used to be because some operations can be done laparoscopically now, or through, I can't remember the right term, but through the ureters and stuff. But if you're using a 5/8, say, for instance, to get to, I believe, around the bladder, not something I've watched a lot of surgery for, but it's difficult to get up under the pelvis and, up under the pubic bone and do some work around there, okay. So that's where 5/8 might be used. Straight needles, still available, less commonly used in some countries because of the risk of needle stick injury, because most straight needles are held by hand. You can hold an instrument and do it as well, but straight needles less common. The straight needles that are used the most commonly now are still used for skin closure, and what you do there, instead of having a stitch that goes through under the skin and takes a little bite and then goes through the other side like a little sort of snake doing that, you effectively distort the tissue by pulling it down and then putting a straight needle in it, and when that goes back to normal, the suture line will be like a little curved needle. So you're effectively doing that with a suture or something like that under the skin, and you can either do it with a curved needle going into the tissue, or pull the tissue out of shape and put a straight needle through it and let it go back to shape, and it achieves pretty much the same thing. That's nearly the end of needles. There are some sutures you'll see around that might confuse you, where you're thinking, okay, this is the material and the needle, and it's a strange combination, what's going on. I'll just mention 3 or 4 of them that you may come across. Double-ended sutures, I've mentioned a little bit. They're used in vascular surgery, particularly, and any sort of tubal surgery, where, say you've got a tube and it's stuck to a wall, okay, so you can't rotate it easily. You have to do repairs where you can't free it up from the wall, or there's something holding it in place, okay. So what you do there is you start with a stitch there and work your way around to the front, and you start with another stitch there and work your way around to the front. So that's why having a needle for the top bit and a needle for the bottom bit works, and then you take the needles off and tie it the other side, or you work your way up the wound like that, okay. There's some needles where you can just pull them off. That's got a couple of trade names. The idea of that is it's a bit like the old eye needles, which I haven't covered on this, but eye needles are not that commonly used in the Western countries. The downside of eye needles is they've got a thicker end, so I actually want to put in a suggestion to help with with a solution as a product that came out from that suggestion, I believe. But you're trying to get it so that the needle and material is near the same size as you can get them. You don't really want to make a big needle followed by a small suture, because you're going to make a big hole followed by a thin suture. The trouble with an eye needle is it makes a a very big hole because you've got to get the material through it. So it's more traumatic. But sometimes what people used to do is put the needle through and then take the needle off. And I think this is still used in veterinary surgery quite a bit. You can buy these needles that pop off, so it's usually used in areas where there's difficult access, and they can do a thing called parachuting, which looks a bit like a parachute, where you put lots of stitches in place with long length of materials coming out from it, and then you slide the tube down to the tube, like down those sutures that are in time, and then you tie each one of those off individually. But in order to do that, you need to put a stitch through and then remove that needle. So cutting the needle off each time is a bit of a drag, so being able to just pull it off can be quite useful. But obviously don't pull it off until you need to pull it off, and that takes a bit of getting used to, because you could potentially pull the suture needle off any suture. And again, that's a change between different manufacturers. Some don't do it very well and others do. So if you're finding that the new needles you're using keep pulling off, that could be because they're not attached as well, or it could be because there's excess drag because the coating's not as good, and therefore you're putting more tension onto the join between the needle and the thread. Loop sutures is a bit strange. There's one needle with two ends attached to it, so the suture goes into the attachment area, goes all the way around, and then there's another end goes into the attachment area, and you might think, well, what's that for? Well, what you do is you get the loop and then you put the stitch back through it. So you go, the loop's like that, you go through the tissue, put the stitch back through it, and then you don't need to tie a knot at that end. And what some general surgeons will do is start at one end of a wound with one loop suture and work to the middle, work at the other end of the wound and work to the middle, closing the mass closure called of the linea alba, or the muscles in the abdomen. And when they get to the middle, they just tie one knot. So instead of having two knots, they have one knot, and that can be a problem. A bulky knot, especially if it's a non-absorbable suture and it's got pointy ends like monofilaments do have, that knot can cause some problems, and people can sometimes feel it, can be irritating. If it's a long absorbing suture, that might not be an issue. But if it's a non-absorbable suture, that knot could be an issue, because it could cause more risk of infection. Wherever you've got more bulk of material, you've got more risk of infection. So anything to reduce the number of knots can be quite helpful, and that's what a loop suture is used for. Beads and collars and buttons, you don't see them as often now. There's issues if you get them wrong, where you put a bit too much pressure on the skin, you can cause some trouble, so you want to watch out how they're used. But basically you have a stitch come out, you put a little round thing over it and a little clamp thing, and that just holds it in place, and you do the same at the other end, so you don't tie a knot. Some surgeons don't even bother with that, they just tie a loose stitch over the surface, and later that's lifted and either snipped and the stitch is pulled out, or if it's an absorbable suture they've used, they might lift and snip it and let it just stay under the surface. Beads and collars are available on both non-absorbable and absorbable sutures. If it's a non-absorbable, then you have to remove that stitch. Okay, well, you should be doing. It's not a good idea to leave it. If it's an absorbable, then it might be deliberate that they don't want you to remove it. They want you to just lift it, clean it, snip it, and let that bit pop under the skin because of the tension you put it under. Or they may want you to try and remove that stitch, but if it happens to break while you're pulling it out, it's not so much of an issue, because what's left under the skin will absorb. So you need to check that with your clinicians, make sure you got the instructions right. The colour of the material may vary between brands that use these beads and collars, so careful with that. It could be absorbable, it could be non-absorbable. Might want it removed, they might not. You need to know that. And buttons are a similar sort of idea, but it's more sort of a closing button thing that holds them in place. The big problem with both of them is if you put the stitch in a bit too tight and the thing pushes down on the tissue too long, you might get a little bit of a pressure sore develop, so you have to be very careful using that. Make sure you get it just right. Okay, so that's the end of the specialist sort of needles section talking about, but mostly talking about curvatures of the needle, blah blah blah. And last thing, packaging. Packaging is incredibly important, really, for the scrub technicians and nurses, ODAs, ODPs, operating room assistants, etc., whatever they're called in your country, in your theatres, your operating rooms. The packaging is your friend, and you really should know. You need to learn it. The first thing you can probably get used to is the colour coding. Most manufacturers have a colour coding, and you'll get to recognise that, you know, the violet suture is one brand and the silver one is another brand, and etc. The blue one, the dark blue one is one brand, the turquoise one is another one. Okay, and you'll get to do that. And a lot of manufacturers have copied the industry sort of leader with that that colour coding system. But like I said before, just because it's the same colour outside packaging doesn't mean it's the same suture inside it. The sterility of the sutures is very important. There are, I believe now, counterfeit sutures out in the world, so you want to be careful with that, because the standards of their sterility may not be anywhere near as good as what you're used to. So if you think there's any danger using counterfeit sutures and you've got the ability to check, you might be able to get, I don't know, microbiology department or whatever to have a look at that. Colour coding on the boxes, on the packaging. You need to learn how to open them. Some of the newer sutures have got better and better packaging. Some of the cheaper packaging isn't that great, and you have to basically try and get through a piece of foil, as they call it, a bit of a thinnish metal with maybe a plastic coating on it, that sort of thing. And you might actually rip through an inner card pack without meaning to, and you could damage the suture in some ways. Probably less an issue with the bigger sutures, but with the fine ones you've got to be very careful with that. Might be that you're best to take the card out and then you can open that up. Some of them you can just rip the foil and the card at the same time. And then there's some more modern packs which have a sort of a tray where the suture's actually packed in a sort of a length and then a curve. It reminds me of an American racetrack actually. It goes like that and then round and like that, okay? And the idea of that is the old style packaging. I've seen people in the factories, they used to have two sort of rods stick up and they'd pack the sutures round like that, like a figure of 8. And when you take those sutures out of the packs, they've got package memory and they look like this. Now sometimes if you hold on to the material near the needle end and the material at the end and give it a stretch, that might get rid of some of that package memory, but be careful. If you overdo it, you'll break it. Don't take it past its sort of tensile, I forgot what they call it, the elongation point. But the more modern packaging, this circular packaging, that has the beauty of reducing the amount of package memory, and also usually makes it very quick to dispense it. And if any of you have had a surgeon saying, "Give me the 5.0 now," and you're not ready, you know what that's like. So if you're getting tied up with packaging, which again, if there's been a change of user, and you've got some packaging that's not as easy to get into, you know, that could be an issue. I know it sounds like it's over dramatic, but I've seen surgeons like going, "Give me a stitch now," you know, and really want it, and you know, waiting 10-15 seconds when something's bleeding like crazy is not a great thing to be doing. Okay, so even packaging can be important like that. Probably the most used thing is just how easy is it to dispense from it, and does it keep the suture in good nick? Okay, is the needle not damaged by the use of it? Okay, and a lot of the sutures have code numbers. In the UK there's W numbers, which goes back ancient history, but people will know numbers of a suture. They'll say, "Give me a," if you talk to someone who was a nurse back in the 1950s, say in the UK, they'll know what 441 is, W441. If you ask a nurse nowadays in the UK what 9136 is, they'll know what it is. They'll be able to describe it in quite a lot of detail. You get used to these numbers. 721, I can't remember, 328, that sort of thing. 1770 was a suture that I used to talk about a lot with ophthalmic surgery. Okay, suture removal. I haven't discussed that much, and the reason is it's not an area of my expertise. I was thinking about this the other day when I visited a friend in hospital. His nurse was just coming in to do his blood pressure, and I said, "Mary, what do you think about doing a little video to help explain sutures?" And she said, "Oh, I was trained a long time ago, but yeah, it might be helpful." I remember one thing I was taught about, you know, if I was opening a big wound and it had lots of stitches in, to take each alternate one out first, just to make sure the wound's healed, and if it wasn't, we could deal with getting some extra stitches in, which I thought was interesting. I had heard of that before, but I didn't deal with ward sisters a lot. I didn't deal with district nurses a lot. I didn't deal with nurse practitioners at GPs practice a lot, so I'm not that experienced in seeing sutures being removed. But I do know there's a general principle is, you know, try and clean things up before you take a stitch out, if you've got to take a stitch out. If that stitch is covered in gunk and you snip an end and pull the muck into the wound, you're not doing the patient a favour, are you? So you need to clean things up, and where you can, you're going to lift and snip and take the bits away. But that's an area probably you need to talk to people who are out seeing your patients, get some feedback from them. It might be that you're using a suture. I've seen this a lot in the old days. People were using an absorbable suture as an external knot, thinking that the suture would fall off quite quickly. Probably they'd in the past used catgut, where plain catgut, which was unchromosized, chromosized stone, a treatment that makes a suture last a bit longer. They thought that when they changed to this new synthetic material, the knots would drop off, and they probably would take about 2 months to drop off, and that's a long time to have a stitch hanging around a delicate part of your body, say if you've had an episiotomy or something like that. Okay, so you can get feedback from others on that, but that's where I go. So this all came from this one request. Can you tell me where I can get sutures explained to me? And I hope this video is going to be a help to that. I am thinking that in the future I may, I'm going to put a Facebook link on here, and I may run a Facebook page if you want to ask more questions, but I'm going to have to be very careful how I answer it, because obviously I can't get into product details. I'm not working for any particular company any longer, so I'm not a representative of those companies, so I'd have to be very careful of anything I said. But if you find this video useful, please, you know, do the normal things of liking it. You can comment on it, and I'll probably be able to get back to you on some of those comments, or subscribe to it. And if I get enough people interested, I may do some more detailed videos on each individual thing. But as you can see, this is a very long video already, probably way too long. In fact, I may have to cut it into smaller sections. Okay, bye, thanks for watching.